Okay, guys, so welcome to tonight's session with myself, Steve Miller. I'm going to be running through something that I really enjoy actually tonight, which is in and around sort of how to manage injuries on the pitch or the field of play or courtside or wherever you might be. And I just find that this is something that we don't generally learn when we are doing our physiotherapy or sports therapy or osteopathy degrees. And it's something that you kind of bolt on afterwards. But for me, it was certainly something that I really wanted to get into. And I probably felt a little bit like a fish out of water when I started. So hopefully some of the little tips and things that you get from tonight, whether you are completely brand new to this, you've never done it before, you're thinking about sort of shadowing somebody, or you might well be someone who's kind of been doing this for a few years and just wants to dive into a different sort of mindset and learn a few little bits. And that's all obviously absolutely fine. So this is what we're here for, isn't it, really? So we're not here just for Harry Kane, even though he's going to be kicking the ball about in a couple of hours against Ghana. But this is often what you see, isn't it, when you kind of envisage someone who goes down on a pitch and potentially has something going on. And your job is often to navigate whatever it is that they've potentially gone down with. So have you seen the injury? What are they reporting? How are they reacting? And obviously, it's really important to know all of your players, isn't it? So if you are working with a team, you know that certain personalities, if they go down and stay down, there may well be a significant injury. If you've got the flip side to that, and you've got Anthony Gordon that's there, for anyone who knows Anthony Gordon, he will go down if the wind blows him too hard and stay down for ages. So again, these sorts of things are really important to try and pick up. So tonight's session's all around that sort of approaching the athlete. What I'm going to go through next month in July, on the 21st of July, is how we manage those big trauma injuries. So things like dislocations, fractures, fracture dislocations, ruptures, all that kind of stuff, really. And then also talk a little bit in and around the unconscious athletes. So that kind of panicky moment where you approach the athlete and they're completely unconscious, not responding to anything you say. How do you manage that? What if they don't have an airway? What if they're not breathing? And how do you potentially extricate them appropriately? So if you are interested in that, then you can have a little scan of that QR code, and I'll see you on the 21st of July. I suppose the question really, and just very briefly, what I'd like to kind of just touch upon is sort of why you should listen to this, and why potentially some of the experiences that I've had might be useful. And I always advise students and other therapists, like on the taping course this weekend, try and pick a sport that's going to give you a lot of exposure to lots of different things. It will give you a wide breadth of different things to look at. So when I worked in rugby, you're getting a wide plethora of concussions, spinal problems, upper limb, lower limb, trauma, soft tissue, a bit of everything really. So you end up becoming quite handy with a lot of different things that are thrown at you. Yes, it's daunting. Yes, it's a revolving door world, but actually you can learn an awful lot in that environment. I then moved into judo, which, just for clarity, I didn't know really a great deal about rugby before, and I didn't know much about judo, but actually stepping into that sort of space, asking questions, being curious, being inquisitive, really helped to kind of give me a little bit of insights into that. But what I'm really interested in, if you haven't already and you've joined a little bit late, please do pop your sort of name and what you do into the chat group that's there. Just your first name. Are you a physio? Are you a sports therapist? Are you a student? Are you quite qualified? Are you working with a team? Just something super brief. Don't need your full life story, but it'd be nice to know kind of who's in the room. And then if you guys have got any specific questions, queries, anything that you want to ask me, by all means, sort of fire them into that group and I'll try my best to answer them. So the material that I'm going to share with you is part of this Be Ready for Match Day course. So it's something I've put together that now I work on the faculty for the FISIS Level 2, which is the RFU course. It's been a nice little opportunity to kind of look at the things that we get assessed on. And it's basically a really nice introduction into that. It covers a lot of that prep work because they are expensive. They're incredibly valuable, and they will test you a lot. So a 1-day course is actually deemed a 3-day course. So you're supposed to put in a couple of days. But I do think that this, with real life examples as a course, is a brilliant way to kind of prep yourselves for things like that. So you can sort of see all of the different titles just on the right-hand side. So we go through some of the prep. We go through kind of the acute injury assessment, decision making on the field that we'll go through. But you can see there's about another 8 or 9 different cases that you can go through. All of them are going to help you to work pitch side, and then it actually has a moulage training, sort of testing yourself at the end. So 10 different scenarios. How comfortable do you feel managing them? And actually at the moment, the whole course is on sale. So if you do want to dive in and watch the whole lot of it, then jump on there. It's only £47. You own it for life, and potentially kind of saves lives and obviously increases the positive wellness of your athletes and players. The last little bit, just as a bit of a promo thing, on Saturday we did a taping course at the Judo Olympic Training Centre. Another sort of 12 physio sports therapist students all graduated, which is great. And I've just put on 2 more. So there's one on the 8th of August and there's one on the 3rd of October. They've all sold out this year. So if it is something that you're interested in upskilling, it's really practical. All the tapings included. It's certified, so you can get your sort of sports taping certification. That'll mean that you can go and do taping straight away, use that for your patients, your athletes, your players, your family members, whoever it is. But it's a really nice sort of day. In terms of the session, so we're going to go through the initial presentation, and then anything that you guys want to ask, anything that you sort of have from your own worlds, I'd really like to hear as well, if there's any examples. We finish a little bit earlier than usual, so about 7:20, so plenty of time for questions. Then you can have a cold shower, and then obviously kind of settle down for the England game if that's your bag. If you are struggling with the heat, I mean, I've got my fan on directly behind me here. It is boiling. It's about 34 degrees here at the moment. If you do need to take a break, it is all recorded this, and I'll upload it to my YouTube channel on a private link, and I will send you guys the link out along with your certificates afterwards. There is lots of other stuff on there, so do kind of feel free to subscribe to that. It's totally free. You just click a button, but it just means you then have access to all the videos that are on there. And if you wanted to kind of get in touch or tag me in anything or take any photos today, make some notes, it'd be great to share them on socials. Just feel free to tag me on any of them. So just a few little welcomes then. Jordana, sports massage therapist, just finishing her sports therapy degree. Welcome. Amy, osteopath of 7 years. Ace, going to go and start working for a local rugby team. A great little world. If you need any help with that, let me know, because it can be challenging depending on how many of you guys are there. Welcome, Elaine. Welcome, Kate, another osteopath and triathlete coach. Son plays rugby. Yeah, you might well get pulled in to help a little bit with that. Hi, Johnny, physio working MSK for local football team. Brilliant. And then Louise, sports massage therapist, level 4, fab, working with a basketball team. So nice little mixture of different athletes and injuries, I'm sure. Some more explosive than others. Lots of kind of patella tendons and Achilles things going on in basketball worlds, I'm sure. And then all sorts of things in rugby. But yeah. So what I'll do, without further ado, I will share the first presentation with you guys. And then what we'll do is kick on from there. And then any questions that you have, what we'll do is we'll let you go from there. Someone could just drop in the chat that you can hear it.
Hey, hi guys. So I'm Steve Miller here at Grow Physio Academy, and welcome back to another session with myself. This time what we'll do is look at how we manage potentially an injured athlete who goes down on the field of play. What process do we need to go through to make sure we're making an accurate diagnosis, and then informing the coaches and the athlete of the potential risks associated with carrying on, really. The session's fairly action-packed, so again, a little overview for you on here. I think it would be really useful to know a little bit of the common presentations that you find. Common things are common. If we know roughly what they look like as they happen, so we can be a little bit more methodical and a little bit more focused on what we're looking at, hopefully that'll help you. So we'll go through things like ligament injuries, potentially clues that there might be muscle tears, tendon issues, maybe concussions, etc., things like that. Then what we'll do is look at sort of the different roles within the team that we're working with and how we come together to deliver a really good package of care. We'll look at the equipment that we need potentially in that run-on bag when we come on and the trauma kit that's required. And then what we'll do is go through a really succinct assessment. So we draw the important, pertinent things out of that assessment so we can make a decision quite quickly. We don't have anywhere near as long, do we, on the field of play or in the moment of battle to assess things completely thoroughly like we would do in a normal clinical environment. So we have to change and alter things that we do. So we only get the absolute essential bits and pieces assessed, and then we can make a judgment whether they can continue, whether we need to monitor them, or whether they need to come off the field. I'm going to talk a little bit around how I've communicated with some of the coaches and the rest of the medical team, so it hopefully helps you when you come to do that yourselves. And then what we'll do is look a little bit at some of the extrication strategies and a few scenarios that I've come up against as well, so you can sort of pick your own sort of experiences against it. Now, just to start with, what I wanted to do is really go through a little bit around what pitchside care is, because it does encompass a whole range of different things, really. Everything from the sort of build up to the match, whether you've been traveling, whether you've been looking after the team through the week, you're going to be aware of certain niggles, maybe people carrying little knocks or bumps or minor injuries into games. So you're going to have a little bit more of a focus on those individuals as you go through both the warm-up and the game. So everybody should be informed in terms of the coaches, the athlete, of what to look for, and that we're maybe sort of looking at little clues that they're deteriorating in some way. Pre-match is really important as well, because we're going to watch them as they go through some of their warm-up activities and see what's going on there. In terms of the game itself, once the match is underway, then what we may well need to do is sort of adopt the position that's required. So that might be anywhere. You can sort of see a few examples here of me. So you might well be on the bench. You might well be patrolling the touchline, and you're able to go up and down. You have the freedom to enter the field of play as you require. If you have a little look at the Commonwealth and Olympic Games setups on the right-hand side, what you'll often find is that actually on table tennis and badminton that you can see there, again, you're not on the court itself. You just set back a little bit, and then obviously kind of the trampoline and stuff on the right-hand side. You can see sort of where and how close you may well be. Now, the thing that might happen, though, which happens in trampolining and gymnastics, is they have multi-events going on at the same time. So as well as covering the area immediately in front of you, what you also have to do is patrol around and see what's going on. The other area you may well be required to stay in is the stadium itself, and then you're only called upon as required. Now, looking after the athletes is the first and paramount priority for you, but it does encompass a whole nother set of responsibilities that you may well require and be asked to do. Some of them totally non-medical. So it might be that examples that you get in rugby are the hookers will often require a towel. If that's really useful, as something that we would carry anyway, if people had something in their eye, they wanted to dry their hands, etc., when they're throwing the ball. You might be asked to relay messages to the individuals. Again, it might be tactical. It might be that you're going on and giving fluids and trying to almost get a little update in terms of what's happening with them. It might be energy gels, might be inhalers, all these sorts of things that you may well be required to do. You may get asked to do some bizarre things. So at the World Gymnastics Championships that I worked at, one of the main things that I sort of got called on to do, it was fairly uneventful, but one of the things that kind of stopped play for the longest wasn't an injury. It was actually someone with a slightly bleeding toe. So one of the gymnasts was running up and down the runway to the apparatus and basically left a trail of blood. Now, they had to stop the event because it was a blood risk. They didn't have access to someone who could take it away. So basically the medical team were called upon, and you go on with your medical gloves and your cleaning stuff. Just be careful that you don't overly clinical wipe them, and then therefore it's wet and slippy on that surface, because then you'll cause more problems than otherwise. In terms of working with acute injuries, I think it's potentially the most exciting. It could be the most daunting, because absolutely anything can happen, can't it? You can have a whole run or a season potentially with just bumps and bruises and a few knocks. But actually what can happen is on any given day, you can end up with a whole plethora of different things, quite high risk, significant things, that are injuries that are occurring. And you have to be prepared for all of them. So if they haven't happened for a little while, it's quite easy to become a little bit complacent. That would be the worst thing that you could possibly do, is stop doing the training and the development areas to make sure you are prepped, because that's the time that you'll probably get found out. Now, in terms of things that you may well get, this can come in all different shapes and sizes, can't it? We can have muscle injuries, tears, impacts, tendinopathy flares, etc. You might well have tendon ruptures, which go off with a bang. We had one the other day in a football game that we were playing in. One of the guys ruptured his Achilles, and this almighty sort of gunshot bang went off, and we were all sort of turning around going, that's blatantly his Achilles gone. Ligament sprains, avulsions, there might be impact contusion injuries, spinal injuries and concussions, might well be fractures that come in all different shapes and sizes, open, close, stress reactions, etc., joint dislocations, and then potentially any sort of medical conditions or anything that some of those athletes have already, or things that they're undiagnosed with may well raise their ugly head as well. So we do have a real responsibility to make sure that these are the things that we're looking after. The other things that we may well get are, there is probably a medical professional responsibility that if someone goes down in the crowd and there isn't cover for them, then inevitably what we're going to do is be called upon to look after them. That might be the same with staff, wider backroom staff as well, basically anyone who's there. So you do have potentially not just the athletes to look after, whole realm of other people. One thing that's absolutely key that I would recommend doing, which we'll talk about a little bit later on, is when you have an extrication route and you're taking someone off the field, walk that walk with the kit, the team and the casualty together before it happens. Because we had an incident recently where we did this in training and realized that a certain corridor, we couldn't turn the scoop and the spinal board in that area. So we had to make sure that we had a secondary medical room that's there. So do be mindful that that might well happen. Now, thankfully, common things are common and rare things are rare. So again, injuries within certain sports will be more prevalent. You may well get the odd anomaly, but actually you're going to become probably quite used to certain things over a period of time if you're working with a certain sport and team. That happened here on the bottom. You can sort of see me and the other physio coming down here. This athlete who we're going to here constantly went down 3-4 times a game, but the whole reason being was he was just knackered and wanted a bit of a pretend assessment to go through so he could get a breather and get back to playing again. Now, you do need to also have a little think in and around sort of what you may well see or what you may well hear when you have these injuries. I would say that this is one of the key things, so remaining vigilant, really, really important. What has happened? Now, you might well see something, but you might well have someone else who's had visibility or eyes on. That might be another player, a coach. It might be potentially sort of analysts, VAR related things who are looking at things on videos. And again, that information can be incredibly useful in order to try and narrow down the mechanism, the structures, the anatomy that may well be injured, and potentially the severity of that injury as well. Now, I've just put on the left-hand side there, I don't know if this has ever happened to any of you before, but you go to try and see how somebody is on the pitch and they go and run off. Now, they're generally just going back into the game if they possibly can. Sometimes you've got to keep a little eye on them. So if they've had a potential head injury, head bang, or whatever it is that you have, depending on the severity and how they're moving, it might depend on whether you chase them, actually take them to one side and take them off the field. Usually you can't catch them. You have to wait until a gap in the play. So you do need to kind of be mindful of that and feed that information in as you require. So let's run through some of the common things that happen really. So high speed running, classic one, isn't it? That maybe a hamstring or a calf or something may well become torn. They may well pull up with it. What they'll usually do is localize straight into that area, hold on to whatever body part it is that's potentially got the tear. When you come to assess them, they'll usually give you the information that they felt like something's gone, they've pulled something, they've pulled up with something, and usually they'll give you that diagnosis straight away. What do I generally look at? What we normally have is put them into a position where we can assess them in some fashion. If it is a hamstring, for example, and they are lying on their back, what I do is put the heel up onto my shoulder and just get them to see if they can knee flex against resistance. Usually that will recreate that sort of sharp shooting pain local to the area of the site, and that for me is almost a stone wall. That's coming off. There's no way that they can continue, and that's that. Now, The implications of potentially having a grade 1, going out and doing some high speed running again, is that it can extend that tear and get a little bit worse. So really important that you nip these ones in the bud, stop them getting worse. They're usually pretty painful also on stretching. And obviously, if they do try and continue, they then go and sprint. Once they get up to sort of any sort of reasonable lick, they will usually break down and report that they can't continue. So that's muscles. If we move on to a little bit around sort of ligament injuries, potentially sort of higher grade ATFL, CFL injuries that you can see here on the left-hand side. Just bearing in mind that this is a completely unopposed tackle. So to the blind eye on the side, it doesn't really look like anything significant's happened. He's just gone straight past him, but clearly the athlete in a lot of discomfort. He's rolled that ankle, torn everything on the lateral complex, and gone from there. Now, conversely, what you can also have is injuries around the knee, but from impact with another player. Now, that can be direct impact, or you can sort of see here in slowed down motion, actually impacts into someone who's with a little melee that's going on elsewhere. Ligament injuries, generally, again, they're very aware that something has happened. There's been a specific trauma. They get instant pain. They know that something's potentially moved into a position that it shouldn't have done. They'll usually localize things very much to that area, pinpoint pain around that ligament complex or onto that MCL in this instance. When they do resisted testing in a neutral position, they usually have very little awareness, and they're often quite okay with pushing quite hard. It's just when you start to open up that area and put extra stress onto that ligament or gap that region that creates that pain. So usually what will happen is they don't want to continue. If they try and put weight on it, they really don't like it. It doesn't feel stable. They try to push off it and they just can't do much with it. If it's a low grade 1 or they've just overstretched things, potentially what you might find is that you can work with that a little bit more. Fractures, again, there's usually some significant incident that has occurred, either direct impact or force into that area. They're pretty reluctant to move it. And what you'll usually find, a telltale sign for this, is that there's swelling that comes on fairly quickly. If they have a lower limb injury, what they'll usually find is that they can't weight bear through it. It's just too painful, and therefore we have to extricate them best that we possibly can. What we'd usually do is go through the same sort of battery. We'd go through the palpation, the range of motion, try and move things, and just basically try and get a gauge as to where they are. If there's a potential risk of fracture, obviously we're packaging that, carrying them off the field of play, and then trying to prevent any further damage occurring to those tissues. Now, we do have certain criteria that we can follow. These are the Ottawa rules, for example, around that ankle. So there are key bony landmarks that are usually the higher risk areas for fractures. So if we know these in advance, again, what we can do is go through a fairly logical step-by-step routine to try to clear whether something is a fracture, whether it is potentially more ligamentous. Usually with a fracture, what you find is that you don't have as much pain, maybe above sort of skin or above there. And then once you start to get directly down onto the bone, you have that exquisite, really sharp, really painful area onto the bone itself. It's worth noting that that could be bone bruising rather than an actual sort of fracture. And also there's the existence of stress fractures as well. So we do have to be a little bit mindful that potentially if somebody has had a stress reaction, their load has been quite high, they've had some awareness, and then things start to suddenly progress, there is potential that maybe a stress reaction is starting to become a stress fracture, and then that can obviously kind of develop and lead to much longer time out through injury. Similar to sort of the Ottawa rules, really, there are key areas that you'll generally find are higher risk of stress fractures. So again, an awareness and an understanding of those beforehand can sort of almost feed into that hypothesizing and clinical reasoning. Now, when we are looking after individuals and we've maybe been working with a squad, we usually have a fairly good idea in terms of what the build up to that week has looked like, what the training load's been like, how they've traveled to get there, what mode of transport it's been, how long have they been traveling for, etc. Now, it might also be that a lot of the athletes are fatigued, maybe recovery has been a little bit down, nutritionally they may be a bit deprived, sleep-wise they may be sleeping in different beds, if they're at away games, etc., etc., might have new families, whatever it may be, it's worth having a little bit of an understanding in terms of the individual and the squad as a whole. Usually what the athletes will do is have a generic warm-up, but they'll often have their own individual prep that they go through, and actually that starts to address some of the underlying issues, we call them, or little niggles, gripes that they may well have. Now, if they haven't had the opportunity to do that, maybe because traffic has been really bad on the way in, or they've had an insufficient warm-up, the injury risk will increase. Injury risk will increase if the weather is horrendous. This is a little clip from at the very bottom there of the Irish women playing football here. Obviously, catastrophically bad conditions. Potential risk of injury could be considerably higher. Puts totally different stresses through the body. Yeah, absolutely awful, isn't it? So all these little variabilities compared to that nice picture on the top left-hand corner there where it's blue skies in France with the team compared to when we went to Newport Dragons at the bottom, again, poses different risks from there. Now, again, before the game has even started, prior to everybody going out, warming up wise, we should, as a collective medical team and the backroom staff, have gone through some element of a moulage or a little practice run of some of the kit that we need to use. So what we'll usually have is a monthly, more in-depth training session, and before every single game is just spend 10-15 minutes just familiarising ourselves with the equipment, because the personnel may well change. Now, it's also really, really useful to go through this with the opposition medical team as well. So you can sort of see the two physios here on the right-hand side talking their way through various things. So they've gone through things like the spinal management. If someone goes down with a spinal injury, what are we going to do? If someone has a medical condition, does anybody coming into this also have any medical conditions that we need to be aware of, be mindful of, maybe have certain things prepped for? What do we do in the situation where there's multiple players? Clearly, if you are the sole practitioner working with your team, you may well require some additional help from the opposition physio, and we're all good people. Usually people are pretty open to the fact that they're willing to help and share that responsibility. It's a great opportunity as well just to familiarise yourself with the extrication routes, the paramedics, where they're going to be positioned, and also if you do require an ambulance, how and where that's going to go. And again, when we think about who we're working with, this is absolutely key, because you might well have a full medical entourage really that you're working with. Usually the higher and the more elite you go, the more specialities there are and more qualified staff that there are, which actually means that you can share that responsibility, and you may well not be the best person to potentially go ahead with some of those management strategies. So again, it's very much looking at what your skill set is, what the other skill sets are within your team, and then what some of the other options are. So you might have to look into the backroom staff. You might have to sort of consider bringing parents on board, training them up, potentially, if you know that they're always going to be there. We know that we need sort of a minimum 6 people, ideally, to extricate safely. So again, if we only have 1 or 2 trained staff, what we need to do is make sure that we sort of expand that and extend that to extra personnel. You might well one day have a totally sort of trained or untrained team around you. In that situation where there's less experience, less skill set, it might be that you become the lead role in that. So again, you've got to make sure that you're leading on a lot of the assessments, so position yourself appropriately. And again, I would just reiterate, like always, practice, practice, practice from there. Okay, some other things to think about in the early stages, really. So if you are going to be aware that there are some individuals who have some underlying medical issues, so it might be physical, psychological, physiological things going on, you're going to have some awareness and probably a heightened sort of vigilance around what is happening with those individuals. So if they're warming up, what we would generally do is keep an eye on what is happening as they warm up. So let's say, for example, someone has a tight calf warming up. They start warming up and they're grimacing. They don't look like they're sort of loading through that side very well. You might need to keep an eye on them, because prior to the game starting, you can probably still make some free changes and change the sort of starting lineup. If they aren't getting through a warm-up, they're not going to get through the sort of 90 minutes or 80 minutes or whatever it is of competition that's there. It's also really worth checking in with sort of the S&C staff if they are the ones who are running the warm-up, if they've asked for any little adaptations. Ask the coaches potentially, are they maybe not performing quite as well? Are they changing the way that they do things to try and protect a certain area? Because fundamentally that might well get worse as the game goes on. If there are issues, then it's really important that you raise them to the coaching staff and potentially the director or the manager prior to the game beginning, so they can discuss different options tactically, what might well be a better option. It might be that they move them positionally into a place that's going to put less stress on that area. If, for example, it is football and you've got a wing back, they're going to go up and down a lot more than potentially a centre half or central defender. So again, it's worth knowing what potential other options there may be, because you might be able to slot it around to make it work, or you have to make a call where you're pulling that individual from playing. Then once the game goes on, really what you're ideally doing is keeping a close eye on exactly what's happening. You're looking for any potential issues. In rugby, it's really interesting because you actually end up watching the game about 5-6 seconds behind where the ball is. So you make sure that everybody gets up after they've gone down, post tackles, post mauls, post rucks, whatever it may be from there. So again, really important to get on top of that quickly. Try and identify if there's anything going on. I really recommend sort of having an occasional scan of the whole pitch now and again, just to make sure that there's not someone who's kind of just lagging behind and the game's moved from one end to the other. This is a scenario for me that I was in very regularly. You can sort of see me here on the right-hand side there, wondering what on earth is going on in the bottom there. Now, it could be that there's a potential try, could be that they're held up, could be a fight kicking off. In my head, and this is what usually happens, is it ends up with a little bit of a tussle in the background. Two of them are going at it underneath all of this melee, but you're just not really sure. So in this situation, it's clearly not particularly safe for me to approach that scenario and see what's going on. I'm going to wait until everybody distributes and then see what rolls out on the back of it. I'm not going to be the one who starts pulling 120 kilo blokes left, right, and centre. So if it is safe to approach, then again, what we need to understand are the rules or the laws of the game that we're working in. Football, you have to be summoned on by the referee. In rugby, you have freedom, as long as you've pre-arranged it with the referee, to go on and off as you require. The risk associated with rugby and injuries is far greater than what it is in football. Not to say that you're not going to have them, but these are the little changes that you require. So you need to make a decision. The other thing I would really recommend is making sure that you don't forget your kit. So the classic thing is, if you see something happen, I've seen this done by other therapists, is they just run like a bat out of hell straight for the action, and then eventually they kind of get there and realize, oh, I've left XYZ behind. Make sure you've got your physio bag, that you know exactly what's in it, where everything is, and then therefore you can use it at your disposal. One little tip I would also say is, if you've seen the mechanism, you've probably got a little bit of an idea in terms of what may well be happening. So think about the body areas that you think are potentially injured. What might the differentials be? What structures might be involved if you've seen that mechanism? And what might your testing plan and order be when you get there? The approach is pretty important. So if you are going to try and run straight for that individual and the game is still going on, as it often does in rugby, what you might find is that you actually run straight through the line of attack from the opposition or your own team. That won't go down very well. Your risk of injury is a little bit higher, so you might need to arc behind the defences to make sure that you're safe. The other thing that's worth noting as well is, if you have a cervical or a potential spinal injury, what we're doing is we're stabilising before we start to talk to that athlete. By putting our hands on and keeping them still, it means that they're less likely to rotate that head. If there's an unstable fracture, obviously that can lead to potential worsening of that situation. So we'd always go into sort of Mills or anterior hold and then start talking to that individual. I've seen this done before where it's a catastrophe, where people go, again, 1,000,000 miles an hour into this. They don't slow down enough, and then basically they slip or they fall or they impact into that individual, or they just run as fast as they possibly can to get there and haven't thought about anything when they're there. So you're better off just taking a little bit of a slower walk. Don't worry about potentially trying to beat the other physio. If two of them have gone down, it's not a race. but take it steady, think about what you're doing, and then you'll be more efficient when you get there. You also just need to be aware of the signals and communication strategies that you have. If you're mic'd up, you need to make sure that you have come up with a strategy with the coaches prior to that. If not, then it might be that you're using signals to indicate what you require, or passing that information on to players to pass on to coaches or managers. If you do need to assess, what I would just say is that you are assessing on the microphone, turn the radio down for a split second so you can get a good understanding as to what's going on. But do say, for the next couple of minutes, I'm going to go and take a full history and I'll feed that back into you coaches as you require. Now, in terms of what's in the bag, I've put together a bit of a video to make sure that it sort of helps you understand some of the things that we had within that world, and then I'll come back to you once it's done.
Okay, hi everybody. So I'm Steve Miller from Grow Physio, and I'm going to do a bit of an introduction relating to what you may find inside a pitch-side run-on bag. So this is what we would have in our Premiership rugby bag that we could draw upon. Again, there's various different options. I'm going to show you everything, and then you can kind of tailor it according to the sport that you are working in. So just on the left-hand side here, what we've got are some of the things that we may decide to use pre-game to help with the preparation with some of these players. But again, some of the heat gels, the deep heats, some of the percutanes and things you may opt to put inside your bag in case something happens out there. Other things that are over here are things like your betadines, like your iodine equivalents really to clean wounds. And then obviously you've kind of got your kind of vapor rubs and things to help with congestion. One massive and really important thing that you will have to have is a collection of gloves. So again, these are single use. We would always have these on and always wear them pitch side. Have a spare set in your pocket. And then what I also had in the glove is a small piece of gauze that we just turned over. So you'd have that in there. I'd probably have more of them in my pocket just in case there was a bigger bleed. But again, you can access that very quickly, use it and apply it to stem the blood flow really. Now, once you've got that on, what you may also have are some life-saving bits of equipment, particularly airway management wise. So if you are on your own, having a couple of these options is a good idea really. So you may have your oropharyngeal airways, which you'll size up accordingly, or your nasopharyngeal airway. The other thing that you will also want to be holding is your pocket mask. So make sure you've got a pocket mask that is available as well to avoid any sort of mouth-to-mouth stuff. Other players may have other underlying conditions or things that they require. Some of these may include asthma, so you may want to get their inhaler, make sure that that is initialed for them individually. And similarly with this, your contact lenses. So I hate putting contact lenses in. So again, it may be a good idea to have some water so they can clean their own hands, use a towel so they can dry them and apply themselves, and you may want to have a mirror at the same time. You may have some diabetics in your team or people who are really lacking any sort of energy levels, but again, these Energels are an excellent option for quickly restoring kind of glucose levels with people. The other kinds of fluids that you might have are salts really. So if you've got people who maybe are cramping or vulnerable to cramps, restoring some of the salts in that world can be really useful. Then clearly we've got the dispensables. So things like your taping options are really useful. So you may have your rigid tapes. What I would do with every single bit of tape is almost unravel the end. So you can see that when you get a new set of tape, what you will find is that it's a bit awkward to get. Even without gloves, it's quite tricky. What I would always do with that is just roll the end over just to make sure that that is easily accessed. So when you've got your gloves on, that can come off the roll really nicely. Other things that you may require, almost like a taillight style strap in. Again, really useful. Comes in different colours and different sizes. And then the other thing that you may have are your sort of EAB strapping. So again, you can see, because the bag is prepped, we've pre-rolled over this and it comes off the roll really nicely. The other thing in relation to that, which are really useful, are small bags. So you could just use sandwich bags. These are official sort of ice bags, if you like, that we use. But again, you can put the tape in. So if the weather isn't very good, the worst thing that can happen is you open your bag up and not everything's absolutely drenched. So again, you can kind of segregate your bag accordingly, depending on what you want in there. The other things that you may have are like a petroleum jelly or sort of Vaseline equivalent for any of the sort of superficial wounds and things. Apply it with a clean glove, get rid of that glove,
and go from there. Other things that we may carry in relation to sort of cryotherapy sort of style treatments, so your sort of freeze gels, just to kind of get on top of acute injuries that way. I think that is pretty much what you would have. Just make sure you've got plenty of spares within your bag, so you don't run out of whatever it is that you need. But hopefully that gives you a pretty good refresher in terms of what we would carry within our bag. You don't have to carry something as big as this. You may opt for like a bum bag. You may have a satchel over your side, whatever it is that you feel is the most comfortable and how much stuff you need. We needed loads in rugby union world, so we always opted with this. And all these products were from Physique, an excellent resource for us at Newcastle Falcons. But thanks for watching, and I'll catch you all again soon. Great stuff. So you now know what's in there. Obviously, tailor that accordingly. And then in terms of approaching the athlete, again, as you go to run on, a few little extra bits that I sort of have picked up that I think are worth sharing with you. So think about that athlete. Have they had any current issues or anything previous in their past medical history? If there has been a history of recurrent calf tears, for example, and then they're reporting tightness or soreness in that area, there's a little bit more of there's a higher risk associated with that, with the repeatability of injuries. Again, think about not just physically slowing down, but also kind of just so you're approaching this from a rational perspective. Think about the game situation, the score, is this potentially tactical, etc. And you also just have a little mindful idea of that. Try to remain calm, but what I would say is you are the person who's in control, so you're dictating exactly what's going to happen in this situation. You might well have someone who's pretty highly distressed. Again, this is a scenario where you're basically just reassuring, making sure you go through a logical step-by-step sort of process, and you reiterate to them. So it might be, hi, it's Steve, I'm the physio. If you've not worked with them before, what we're going to do is go through a logical process, make sure we work out exactly what it is that's going on. That might involve me going through some testing, but it does require you to do some movements and some resistance work against me. I need you to give me a full sort of good account in terms of what it is that you've got going on pain-wise. You may want to grade it on a scale from sort of 0 to 10, etc. So you get a really good indicator. Again, reiterate, it's really important that you give us a true account in terms of what's happening, so therefore we can make the best decision and management plan possible. If they are in this position, you can see this guy has gone in and he's really close in, getting a good indicator in terms of the sort of face-to-face contact or direct vision with that individual. But again, he can't really assess that individual in this position. So if it is something like a knee or an ankle or something like that, we need to get them on their back and have a little look at it from there. Again, we went through the run-on bag, but whereabouts is everything in the heat of the moment? You don't want to be just rummaging through, wondering where things are. You want everything organized, know where everything is, so familiarize yourself beforehand. And again, if you do have an individual who's down, also think about, is there anyone else who is potentially involved in that? Is there anyone else who's at risk from there? Now, one little tip that I tend to do is you usually carry ice in a sort of an ice bag that you saw there, rather than the one on the right hand side. But quite often, as you're communicating with that individual, potentially putting an ice pack or something onto the injured area can do very little, if not no harm. It's not going to have a massive effect in terms of significant cooling of the area, but it's going to potentially demonstrate that you are having some sort of acknowledgement, some sort of intervention that you're there for, while you maybe communicate a little bit further to get that extra bit of information that you require. On the left there, you'll see the classic old school cold spray, which is probably the best case scenario. If someone says, just give me a quick little spray. Again, it's a visual acknowledgement for them and the rest of the team that they are this big, tough individual who's battling on with something because they've had this sprayed. It's just an acknowledgement quite a lot of the time. It's not doing anything particularly physiological. You could argue in some respects it's adding a little bit of sensory desensitization, potentially, but realistically it's just an acknowledgement more than anything. One of the big things that we need to do quite cleverly is work out whether something is a big problem. Like you can see on the left-hand side there, we've got a spinal injury that needs extricating and taken off, much like fractures. compared to maybe something like it is on the right hand side where they're sitting up, they're moving, all they want is just to reinforce some finger tape. What you're required for will vary significantly, but again, recognizing early what sort of people, if any, do we need around us, and what equipment do we need so we can get that there as soon as possible. And that requires a pretty logical sort of process and approach, really. So what I would do usually is approach the athlete. So you've been called on, or you've been allowed onto the field of play, and you've approached them. You're then going to go through some observations and a verbal assessment. Again, relay all those sort of reassuring factors. This is the process that we're going to go through. We're going to go through some testing on this to make sure that we decide whether you're able to continue or not. That's going to then either result in removal, substitution, or they can continue playing. If you have, at that stage, a question mark over whether they still can continue, and it's not a very quick, yeah, I'm up on my feet, I'm back as normal, what you're going to do is undertake a more local assessment, aren't you, of that area. So based on some of the things that you might have picked up from the mechanism of injury, you're going to perform a local physical assessment. That might well then confirm your judgment that you're going to remove or substitute them, or they're able to continue. From that, what you're going to do is then inform the coaches, let them know what your decision was. They don't need to know all the medical jargon or the medical diagnosis, etc. It might be something that you just keep really simple. It's his knee, he's taken a ban, he's going to be okay to continue. What we'll do is we'll just monitor him from here on in. Because the conversation with the athlete may well be very similar, or it might well be quite different. It depends on the severity of the injury and what the implications potentially are. Might be with the athlete, let us know, looks like you're all right, give us a shout if things start to deteriorate or you feel like your performance is becoming affected. I'd always, with any injury that I've gone on to see, monitor that individual as well as trying to keep an eye on everything else. So the problem and the challenge is if you've got 3 or 4 people who you're trying to monitor and look at everybody else, it can be a little bit of a mind boggler for you, but that's just the reality of what's happening. You may well want to ask for additional bit of help. So ask the coaches or maybe the doctor or someone like that, can you keep an eye on such and such while I keep an eye on these guys? And if there's any signs that they're deteriorating, or actually if they're going the other way and they look like they're doing fine, just let us know. If you are happy with the local assessment that's been done and you've done sort of a more sort of fitness or physical testing assessment, again, you want to feed that back in and let them know how things are. Realistically, all we're trying to do is mitigate the risk that's associated with that individual based on the symptoms and the signs that they have at that time and the implications of them continuing on in whatever sport it may be. So we're picking up on all the signs and symptoms and balancing that really with that individual. I've just put on here, remember that you are there for your expert medical opinion. You are the medical professional who's potentially that first person on site. If that is something that you need additional help with, ask for additional help. If you're there on your own and there's no one else who's better qualified to do it, you are making that decision. And if you're not sure, err on the side of caution at all times. On that, though, what you might well find is that you cannot obviously bring every single individual off who has any sort of bump or niggle or bump. Because realistically, you're going to end up with no players on the pitch and the game's going to get abandoned. So it is a balancing act. You do have to try and do what you can to reduce the risk at times. So it might be that you are intervening in some way. It might be that you're advising some ice. It might be that you're taping something. It might be that you're changing them positionally. It might be some sort of tactical change. It might be you've got roll on, roll off subs and you want them to come off, or you take them into the medical room for some further investigation to decide what the best strategy is, or you wait till half time if there's a couple of minutes left so you can get a better look in terms of what's happening. If you do need to remove them, you have to kind of instill the reasons why, what are the risks that are associated with that, or you just have a very firm, this player's coming off, it's unsafe for them to continue. If they aren't coming off, it does pose a little bit of a challenge. That's where you've really got to almost have the coaches on side. And if the coaches aren't willing to take them off and you have something like a concussion, again, for the athlete well-being, that's where you have to almost alert the officials, let them know that this player is unsafe to continue. They're at a risk of worsening their own health, and then you make that decision from there and face the wrath after. A lot of things will be said in the heat of battle. That is when emotions are running high. It's a high stress, high pressure environment. Winning is really important to a lot of people who are involved in sport, so clearly that can happen. But what I would say is make a medically informed, firm and logical decision. And if you need to use caveats that are alongside that, then do so. And what I mean by caveats are potentially, if this player does continue and develops this, it may well develop into what could have been maybe after the match a 3 or 4 day turnaround to maybe, if this becomes a grade 2 hamstring tear, it may well be 6 to 8 weeks. And what can we do in between? So on the left-hand side, very little. Spraying an area. Tape over the boots is something that I see all the time. Don't get me wrong, I have done it. But again, it's sort of something that a lot of people like. How much impact it has, I'm not really sure. But you can sort of see variations of strappings of knees and things from there. And if the decision is, even after all of that stuff, that they're still not right, they'll just have to come off the field of play. So here's a scenario for you. So imagine that you are in the moment. You are the therapist who's looking after a team. You have an individual who goes down. They're rolling around. They've grabbed their knee in this position. They're obviously in a lot of distress, potentially. In this scenario, what are you going to do? So you're going to think about the process that we just talked about and some of the ways that you'd approach it. If you want to pause the video, do so and go through some of the various different potential diagnoses, tests that you might do, and some of the variability. So based on what they tell you, it might send you down one avenue. If they say something else, it might be something else. Yeah. Now, it is really important in this situation to know your athletes. You've obviously got someone there who's kind of hands over their eyes, potentially really in distress, or it might be that they are, shall we say, continental, and they maybe are trying to get someone booked or whatever it may be from there. So a little bit of a cynic in me. But again, if you are an athlete like either of these two on the left-hand side, ridiculously tough, never go down unless there's something significantly wrong with them. They're ones where I'd be really sort of getting to them pretty quickly and working out what's going on. It's highly unlikely if either of those two went down that they'd carry on. But again, really, really important. Know how different players potentially react to different types of injuries. And I'll show you a couple of them in a second. So this is the classic, isn't it? You've got Neymar here, gets a tiny tug on his shirt. Looks like he's been assaulted, GBH-wise, from someone from there. Rolling around, clutching any part of his body that's happening. Obviously, the defender's disgusted. That's one extreme, isn't it? So you might well have a really animated player who may or may not have a warranted reason for that. The alternative to that is on the right-hand side. These are the ones who you actually want to be more worried about, the ones who are rolling around, clearly got an airway, clearly got full control over their bodies. The motionless athlete who's not screaming, not kicking, not rolling around are actually the ones that you want to go to before you go to this person who's rolling around all over the floor. Let them have their moment and make sure you deal with the ones who really kind of need that attention. The risk of potential A, B, C, D problems with this individual on the right, far higher than the one on the left-hand side there. If you do have someone who's highly sensitized, so they've got maybe low pain thresholds, etc., really distressed, don't let that stress affect you. Remain calm. Have that classic sort of swan approach. Legs or heart might be going like the clappers underneath the surface. Remain calm. Be confident that you have your process and you're going to reassure that individual of the process that you're going to go through. The odds are that there's nothing really significant going on that isn't going to be managed. It might be one that you need to take a little bit longer with, but most athletes will get safely off the field of play without any further deterioration of symptoms. Yeah, the initial stages, obviously, kind of emotions can be really high. As I said before, it might be that potentially putting some ice on to that problem area may be something that just helps while you're communicating and get a little bit of a better picture in terms of what's going on. What I would recommend with those individuals who are really sensitized and don't want you going anywhere near that injured part is just start further away from it. So start palpating something that you know has absolutely no connection muscle-wise at all, or joint-wise with whatever it is that you're potentially dealing with. It might be that you even have to start with just a light sensation check. Can you feel me here? Can you feel me here? That kind of thing just buys you a bit of time for all of that initial sensitivity to settle, so you're not just watching them screaming and rolling around on the floor. Again, as well as palpating above and below, what you might decide to do is, if it's something like a knee problem, can they move their ankle? Can they move their hip? Can they rotate themselves femur-wise, etc., etc., before you start honing in locally. The more that they realize that they can do, hopefully that desensitizes them gradually enough to start to move that problem area and then realize that there's not really a great deal going on. If they're really struggling to move it, what you might need to do is offer your support to help them move that injured area. They may well say, don't you dare come anywhere near it, I'll do it myself, and they hold their own limb, which is absolutely fine. But again, if you're kind of buying into a collective with this individual, really nice. Can we move the part together? What if I try and support it or take the weight out of it and you go with the movement? So you're almost just guiding them as they go to move that area. If they do it actively, initially, they may well, again, try and be a little bit desensitized, or if they're passively moving that area, it might well settle a little bit better. If they're taking ages and they're rolling around and they're not letting you get anywhere near it, I often come in with this line: if you don't let me assess it, you're coming off, and then we're down to potentially 10 men for the time being. That often flips it to, oh, actually, I better allow the physio or whoever it is, therapist, to go through this assessment from there. But it's really hard to judge, guys, isn't it? And I just want to sort of take you through a scenario that I managed. So this was me sort of at a team gym event, covering for the day. There was only me there, watching this sort of team dance routine stuff, one after another, loads of people flipping around, being thrown in the air, etc., etc. And basically what happened was, one of the girls who was in the squad went down after being thrown and doing a somersault, and she landed awkwardly on her ankle. She actually completed the routine, but then after the event basically became incredibly emotional on the crash mat, wouldn't allow anyone else to kind of come nearer. Again, I hadn't worked with her before, so again, the difference between knowing your athletes, it was a completely blank page. What am I going to do with this? So again, went over, hi, I'm Steve, how are you doing? Crying, screaming, not letting anyone near it, not letting anyone touch it, not even engaging in conversation. Go through, okay, what I need to do is go through an assessment of this injured area and see what's going on. If you don't let me do it, we can't work out exactly what it is that's happening. It might well be a little bit painful for you, but I'm not going to push into too much pain. If you're not happy doing anything, let me know. You're going to guide it. I'm going to put you in charge and give you various different options. Does that sound okay? Yeah. Still really upper height. And I just thought, well, I wonder if this is maybe because she's younger. She was an under 18. Was it the first injury that she'd had? Did she have a really low pain threshold? All of these things were going through my head in terms of what's happening. Had maybe they been aware of other injuries that other people had had or they'd had in the past, and they'd made comparisons thinking, God, this last injury that I had put me out for 6 months. I'm really upset that I'm going to miss it. All these kind of things are going through my head. She wasn't giving me anything. Well, it can also be due to things like muscle inhibition and apprehension moving because they just don't want to do it. Again, sometimes what happens is the more they start to move it, they realize, oh, it's actually not as bad as I thought. And then things settle down amazingly quickly once that emotional driver has settled down. Was it also potentially due to quite a noisy arena, the pressure that's maybe coming from crowd or coaches, interference from parents, etc.? All those kinds of things are all kind of going through my head because this girl was taking ages. And what transpired in actual fact was she'd rolled her ankle slightly. She had barely a grade 1 tear. But what she was really upset about was she wouldn't be able to be part of this event, which was the following one. So they take it in turns. They kind of rotate around 3 events. And then they, in order to be part of the team, she was one of the best jumpers in the squad at this. They could run it with one less individual, but it wasn't until she had a conversation with a coach explaining that they don't need her for the next event, that she suddenly became a lot more on board and managing it from there. So again, is there something that's at stake? Have they blown chances that they've been working for ages? Do they feel this sense of letting their team down? Or is it a kind of an injury realization in terms of what's going on? In terms of sort of my approach and what I was thinking when I went into that situation was it was very simple to kind of establish where the injured area was. She was grabbing a hold of it, not letting anyone anywhere near it, screaming, crying, etc. She was obviously in what seemed a lot of distress from there. I asked her to describe some of the symptoms that were there and also what do you think that you've done? So I went down the route of actually anatomically, is there something that you're particularly concerned about that you think that you've done? She wasn't really thinking in that fashion. What she was more bothered about was letting the team down on the other way. So again, this is the classic one, isn't it? With a sort of within a sort of footballing world, really. Physio goes on. First question, I think, what do you think you've done? What have you done? It's a rare situation where you get a chance before you even look at it to get their opinion. Usually what it is the athlete looking at us for the answers. But actually, if we go in straight away with a what do you think that you've done, it can really sort of almost fast track your way to finding out more about what is actually happening in and around that area. So that is one little tip that I would say is almost go into that world and just ask that simple question, and you might well cut out a lot of the bits in between. You'll get a lot of the clues from the verbal and the body language in terms of potentially the severity of that injury. I would also ask them, do you think that you can carry on? A lot of them might well turn around and go, yeah, just give me a minute. Other ones might go, oh, just do you mind just checking this or having a little look at this to make sure it's okay? Or can you put a bit of spray on it? Or absolutely not. There's no way that I can carry on. I know that this has potentially gone. Important things to go down. Has there been any audible noises, pops, cracks, crunches in and around knees? Really important to try and really hone down in terms of what they did feel, where they felt it from. That might well help guide you. Is it ACLs? Is it potentially meniscal? If it's something like a knee problem. What are their previous injuries? If you can't remember or you haven't worked with them before, ask them if they ever injured this part of their body beforehand. Has there been anything that's happened that leaves them a little bit more vulnerable in that area? Early swelling is a key indicator for me. If something after you go on immediately swells, I'd really be thinking that there's a more significant injury that's there and they won't be able to continue, be it ligamentous, sort of grade 2 plus, be fracture sites that really swell up amazingly quickly from there. And again, it might be one that you go through your assessment, you don't think that they should continue, they want to continue, you might have to be succinct in terms of the risks of continuing may well lead to X, Y, Z. It's also important to feed that back into the coaches. So again, what you might well want them to know is there an immediate change that's required? Knockouts, concussions, fractures, dislocation, hamstring pulls, it's gone again, etc. All the kind of areas that you would be making immediate changes with and not messing around. Let them know early so they can make plans. If you need some time to assess it further, let them know. Usually what we'd have is if I said that, the manager would always get the substitutes ready as soon as I said I wanted to assess because they're thinking about possibilities that are going on. Again, this terminology is worth ironing out beforehand. If you need medical kit on in an extrication team, obviously they're not going to come back on again. And do you expect the athlete will carry on is the classic question that you get given. A yes, a no, potentially are the three. Usually what they'll want is a yes or a no. In terms of where the assessment should take place is also another question. So in rugby, what you might have is you go on the field, you're assessing while the game is going on. In football, usually what will happen is you'll be beckoned on, you'll go through your assessment either on the pitch and then they have to come off and be let back on again, or you take them off to the side, assess them there. Let the referee know to stop the game if there's anything significant, or you let a fourth official know. Whether it's on the pitch, the sidelines, or the dugout, it doesn't really matter. It will give you a protected space to potentially have a little bit of a further look. And if you have the option to make a temporary or tactical substitution, if you need to explore this a little bit further, I'd always take that because it gives you a little bit of time to go through this in a bit more detail. If it's more of an intimate or extensive examination that you require, I would get them away from the prying eyes of the public, out the way, and make sure that you take them into a medical or private facility to go through that in a bit more detail. And again, it kind of depends. If you are a sole practitioner, you may well have to stay out there and angle yourself so you can see what's happening on the pitch at the same time in case anyone else injures things if the game goes on again. Or what you might be able to do is ask the doctor to keep an eye and radio through if there's anything that you require from there. When I worked for the LTA, covering some sort of events in that world, what tennis has is quite an interesting situation, just to let you know. What you're allowed to do is come onto court for a medical timeout. You can go through an assessment for up to 5 minutes, but as soon as you start treatment of any sort, massaging, strapping, mobilizing, whatever it may be, they start a clock and you're only allowed a maximum of 4 minutes. Obviously, if it's a more intimate area, so we had someone with a chest injury with a female, so it was very much a case of making sure that she was taken off court so we could have a little look at that in a little bit more detail, but we were chaperoned by the referee's assistant from there. The other question that comes up quite regularly is who should lead or conduct the assessment. So if you are the most qualified person, the most appropriate person for that assessment, that might well be you, but that may well not always be the doctor. So if we have a sports med doc, usually they are the ones who will lead. But actually, if you are sole practitioner or you're away from a medical facility, you may well be that person. So it's really important to consider the skill sets and who's the most appropriate to lead on that acute injury or sort of respiratory assessment. And that was really flagged when this is something that happened to me again. I was cycling home from work in the old cycle lane, and basically a car ripped out from the side, took out one of the sort of pedestrian cyclists, if you like. They went flying up in the air and landed on their head. I went onto the scene, parked my bike up on the side, went to go and see how they were doing, and already a homeless guy had come out from outside of the supermarket, Sainsbury's, on the corner, had them in a like an anterior hold position, was going through a sort of step-by-step logical process, really. So this guy obviously knew what he was doing. I'm assuming sort of potentially ex-military or whatever it is, but total assumptions. But he was going through a very logical, methodical approach in terms of how we maybe look after this individual. When I came on as well, again, sort of had that conversation. Are you happy leading? Background wise, this is what I've got. I've got a pitch side emergency care course that I've done. Do you feel happy, confident conducting that from there? That was superseded by a GP who then arrived on scene with a SATS monitor, basically stuck that on, which was great, so we could get a little idea of that, and basically said, well, you need to get this person off the middle of the road as soon as possible. Someone grabbed the arms, someone grabbed the legs, and we went, there's absolutely no way that we're doing that. So there's a potential risk of spinal injury. They had neural symptoms in their arms and one leg. There was no way we were going to move them unless we had official equipment, paramedics, etc., to move them. So you might well have doctors, GPs, people who are maybe great in certain areas, might be consultants, best knee surgeons in the world, but they may not be great with acute management. So just bear that in mind. And also there's things like rules, etiquette. So judo, only the doctor is allowed on. You may well only be allowed international federation doctors who are allowed onto the field of play to start with. And then they'll summon people on accordingly. In terms of what you'd look at, again, when you've assessed, you're going to have the conversation, try and hone in what it is going on, go through some of your palpation techniques, try and work out and localize what it is that's maybe affected. Then what you're going to do is go through a range of motions. So I would always go through the predicted, less painful movements first of all. So if you do have an ankle injury where you think plantar flexion inversion is the injury, I would always ask them to kind of wiggle their toes, bring their ankles up to start with. So you're going out of the painful range to start with before you go into some of those more potential provocative positions. I generally ask them to perform that actively, whether they hold on to it themselves or not. And then it might be that we do it a little bit active assisted. Whether or not we apply overpressure to it will depend on the severity of the injury. Again, if it was an ankle, what I wouldn't be doing is ramming that into plantar flexion inversion and applying lots of overpressure. unless it was really sort of low risk from there. In terms of ligaments and what we're looking for, if we were looking at potentially doing some special testing, it might be that we have a bit of a palpate again over that ligament. What is happening when we look to gap it? What does the feel like? So a ligament generally has a good end point. If that feels empty or it's really lax or swinging in the wind and opening up and gapping on one side, we've got a significant ligament tear that is not going to continue. We need to package that and get them off the field of play. If you need to do some special testing for whatever reason, same sort of thing applies. Try and expose whatever it is that's there and then almost have a little bit of a look in a bit more detail. Now, if you've had a look at them locally and they look like they are able to maybe undertake some more functional testing, almost like fitness testing things, what you try and do is have a little look at what they're like with some resisted testing and then bring them up into weight bearing. So again, if someone has maybe something like this, like a hamstring, that feels like it may well have become tight or they've had a sharp pain in it, pushing down into that individual's shoulder can be a really nice indicator in terms of whether or not there is potential tear that's there. If that's sharp, again, we're going to basically say that you can't continue. Or if there's absolutely no power in it, again, because they're reluctant to do it, they need to build that up to a level that you're happy with, that there's enough integrity in that muscle. Once you've got them through that initial functional test, get them up into weight bearing. You might need to get them to do a little bit of a jump, double leg, single leg, hop in, maybe jumping side to side, little jogs, little sprints, etc. Make sure that they're okay to the best of your knowledge, and then monitor them from there. At this stage, really, once you've done that, you need to feed that back into the coaching or manager from there. Same sorts of things, really. Stay really succinct on the radio. Avoid medical language and terminology that might be a little bit complex. They don't want to know that it's a potential grade 2 anterior talofibular ligament sprain. What they want to do is say he's rolled his ankle, looks like he's done X, Y, Z. Can they continue, or do you need to do a further assessment, or are you going to immediately remove them from there? Now, if you are going to remove them, there's various different ways that you can get an individual off the pitch pretty safely. And usually you will have come across the most simple ones where they walk themselves off. So imagine you've got this scenario. So you've got an athlete who goes down, maybe a non-contact injury, significant moment where they've heard a pop in their knee. Likelihood is they've potentially done something structural, likely the ACL. This is what usually happens, isn't it? The athlete's down. There's a swarm of all of their own players to check their welfare and make sure that they're okay. Then the medical team gets summoned on, and then they go through an assessment. They clear everyone out the way. They have a look in a bit more detail, see if there's any differences, asymmetries, any previous injuries that may have indicated that that's going on, any swelling, etc. And then they make a little bit of a judgment, don't we? So we decide this is what's going on. This athlete's not going to carry on. They've had a pop in their knee. You maybe avoid a definitive diagnosis, so you don't say this ACL is basically torn in half. What I would do is say there's been a pop in your knee that could indicate something structural within there. Let's find out in a bit more detail, but at the moment the risk of further injury is too high for you to continue. That always goes down like a little bit of a lead balloon with athletes, because probably the realization that they've injured themselves, they may well be looking at a lengthy time off the pitch or training, and they're often angry and emotional at that time. They try and charge off from there. You're going to help that athlete best you can to support them to get off. If they're able to fully weight bear and walk without any problems or pain at all, then for me, it's absolutely fine for them to walk off with support. Think about the way you're going to get them off. Is the most direct way the safest way, or do you want to get them off the pitch and then walk a little bit further just to avoid any potential risks? You're going to radio in to prepare a lot of the things in the background, and then once they get there, realistically, they're going to either jump on the bench, put a big sort of subsuit on, go through some extra testing potentially a little bit later once things have settled. Give them some ice, give them a coat, and give them some fluids for now. If then unable to weight bear at all through that side, what you might need to do is assist and help them off the field of play. If you don't have any equipment, that can be just an arm around each side or if they can partially weight bear, they can't put all their weight through, again, they can touch weight bear from there. Do think about the direction of that extrication route and where the best way is to get them through for that. That should be something that you've rehearsed. Everyone should be aware of where we're heading. But again, making sure that they're going feet first as they come off the field of play if they are packaged up. It can be interesting, and it has been interesting in the past, overcoming some of the challenges of extricating. It seems pretty simple and straightforward when you've got someone who's been extricated from a field that is fairly dry. These are some of the scenarios that I've faced myself. So when I worked at the Olympics with volleyball, obviously playing on sand with beach volleyball, it's an unstable surface. And again, different approaches that you require collectively come together and work out how you do that. That's the same potentially if you're getting someone out of a pool. Gymnastics is really interesting. Obviously, it's quite squishy. Trampolining is a nightmare if they go down and they're on the trampoline, because once somebody goes to move, the whole entire bed moves as well. So again, what we generally do there is stack underneath with loads of those crash mats so there's as little movement as possible. One person moves at a time. We haven't got multi people moving, and also we're trying to spread our weight as best as we possibly can from there. Really interesting challenges as well with people who work in snow cross that I was talking to. If they've got helmets on, have spinal injuries, etc., what is it that you do? So all about kind of getting together, getting your heads on it and working out what works. And it might be that you have to package that individual. So if you haven't already watched it, watch the MSK Trauma webinar about how to apply a lot of these supports and frat pack tools, because you might well come across something that looks a little bit like this. Now, whether you are able, qualified, confident to relocate these sorts of things depends on your skill set or the team around you. But again, if that does present to you, if you want to pause this, go through a little bit of a scenario in terms of what you would do, then please do so. One of the last bits really of this talk is just to get you familiar with the trauma bag. So if you do have a green bag, these are some of the things that are in there. Really important that you know if you're passing them to somebody, that you know where they are, or if you're using it yourself, that you can find things really well. So I'll leave you with this and then come back for a little bit of a wrap up.
Hi everybody, so I'm Steve Miller from Grow Physio, and I'm just going to talk you through some of the trauma and life-saving equipment that we use at Newcastle Falcons. So over here on the left-hand side, this is the trauma bag that we use. So within here, this is predominantly managed by the medical side of things. So the medics will be in charge of this. Inside of there is the airway management stuff. We have the wound care and wound management stuff like the suture kits. We also have the collar that you would use for extricating a player with a neck injury or a spinal injury, as well as a lot of other bits of equipment in there, like the medications, the drugs that can be administered by a doctor. Other things that you will want, ideally, again, it depends on your budget, but this is an ideal scenario. This is a SAM pelvic sling, or SAM splint, as it's known. Basically, you have on your floor, or 5 more, your pelvis is a huge area that can bleed, as are sort of the long bones as well. So around that sort of proximal femur territory and pelvis, really, that will stabilize the pelvis to stop the bleeding or reduce the bleeding somewhat. Other things that clearly you will be fairly familiar with are crutches. So again, if you want a partial weight bear, non-weight bear somebody, these are a really useful option. A couple of things just to check with this, again, are making sure that the handles are okay. We used to apply a little bit of foam and a little bit of tape around here just to add a little bit of, so there's less pressure through the wrist really. And you just may need to make sure that the ferrules are all in working order. Just a couple of demos of those that are a bit worn really from there. And obviously these are adjustable to the height that the athlete requires. A knee splint, again, for any knee-related pathologies or injuries that you want to stabilise. Really useful having a option that has the angle that you are limiting that range of motion at, so that maybe that you don't want any movement at all in a knee, so therefore you can brace that accordingly. Some of them will allow a hinge up to a certain angle. Other things for upper limb injuries, just your slings that, again, people will be fairly familiar with. Used to have a lot of AC joints or upper limb pathology stuff in there.
You've got your air cast boot, which again has an inflated section inside. So what you're doing is you're obviously picking the right size, and then you are pumping up the inside so it splints and braces that lower limb accordingly. Any ankle injuries, foot injuries, anything that you think that maybe just needs stabilizing, again, a really useful option. These are the life-saving bits and pieces here as well. So this is your AED or your defibrillator. Really important to check that the battery life is at least half on that before you are embarking, and that should be done on a weekly basis as a bare minimum. The pads need to be in there. You need to make sure that they are sticky and that they have been maintained. Other bits of life-saving stuff that you need to check, just for example, are oxygen and also this, which is your Entonox. So Entonox is something that you would use to maybe sort of relocate a joint if it was appropriate to do so, and they're neurovascularly in check. And then obviously the oxygen, that again needs to be at least sort of half full. And again, it's been checked beforehand. The last thing just on here really are your sort of support, so your back splints really. Again, you're going to just pick whichever one you want to use. You're going to mould it round whatever limb it is that's injured, and then what you're going to do is just draw out the air with that, which will then cause it to harden. So you can see there's a pump attached here, and in a very easy sort of fashion, basically pumping it out the air, that will solidify, and then you can package that accordingly and get that off to A&E, hopefully preventing any sort of worsening of the situation. But hopefully that gives you a little bit of a flavour of the trauma and life-saving equipment that we would use here at Newcastle Falcons. Hope you've enjoyed it. Hopefully you use it to your benefit, and gets you ready for the sport reopening again.
Great stuff. So just to summarise then, in terms of once you've had an athlete who has potentially injured themselves, you need to think about the sort of aftercare afterwards. So again, what is their situation? Do they need to have somebody potentially drive them back home again? Do they need a chauffeur? Is that going to be an ambulance? Do they need someone to accompany them to the hospital with them? I always add the caveat to them as well, that if things do deteriorate, then what we need to do is make sure we get them to the medical room appropriately. So they will signpost them to A&E, and also give them a document that will almost outline exactly what it is that's going on from there. If they're going home, then what I would do is almost make sure that if they are living alone, or they're staying at friends, or they've got a partner, that the partner or friends keep an eye on them for that night. So if they are in maybe a little bit of a position where they may well deteriorate, if it's a concussion, head injury, that kind of thing, again, really important that we keep an eye on them and make sure that they're okay and don't deteriorate. In the documentation, what I normally do is almost just summarize in an Atmist kind of handover fashion some of the key bullet points. So if they do need to go to hospital, then they've got that information there with them. The other thing which I just want to do is sort of just almost, if you do let somebody go, or you have had an injury, what may well start to happen, which is interesting in this scenario where my little boy had a clavicle fracture. He came back from a football camp. He played for about 20 minutes before being fouled and landing awkwardly on his shoulder. He then had fractured his collarbone. I rang a few people and just said, it looks like it's fully union. What should we do with it? They just said they're not going to do anything with it, but basically put him on pain meds, etc. When he woke up the next day and moved around a little bit, he was sort of saying pain's not too bad, but you can see how significant the shift is that he's developed. So it's just to highlight really what can happen is they may well posturally change. So some of these things might well happen pretty quickly. And it's quite interesting. So if they have had a significant injury, but maybe they're quite tough or they're playing it down, they may well be finding ways for them to get around and move a little bit easier. You can see him on the right hand side looking a bit happier with his sling in situ. Fine. So just to summarize, if you haven't already, definitely set up some training, go through some scenarios, some moulages. If you want to go through some classic ones that I've dealt with, I've put them together in a separate presentation. So go on there, test yourself, give yourself a chance to answer what you would potentially do, and then I'll sort of walk you through the way that we've managed some of those. So yeah, head across to the that presentation, and that will hopefully help you a great deal to put a lot of the theory into practice. So, key things to take home from this. Common things are common. You're still going to have your ABCD approach and then look at everything else. That is going to be the mainstay. Most of the time, if someone's injured themselves, all of those things will be in situ, and they'll be talking to you and being fine if it's something peripheral. Communication is absolutely key. So, what we've got here is actually the key things that the athlete, the coaches, and potentially the media may well be savvy to. So if you are discussing something in front of an athlete, be very mindful of what it is that you're saying in terms of the diagnosis, what they've done, how long it may be, and putting a direct label on exactly what that is. So if there are certain things that you want to keep from the athlete, then what I would do is get them off and have that conversation once they've been put on the bench, etc. Try and keep your assessment as succinct as you possibly can. Ask them what you think that they've done and can they continue. Are classic good starting points that are there. They may well give you the answer straight away. You're going to have to back that up with your medical findings, but that's a good little starting point. Monitoring and then rechecking the athletes is also absolutely key. So you're going to look at them functionally. Keep checking in to look at how their performance is affected. If it's deteriorating, then you may well have to intervene. People will generally look like they're unable to maybe run as well, change direction. They might not be able to sprint to the same intensity that they were before, etc., etc. So performance-wise may well be affected, which may actually then lead to potential problems if that person can't perform and it leads to a goal or a try or whatever it is for the opposition. Packaging and practicing is absolutely key. So get used to packaging the athlete appropriately to make sure that you don't worsen the situation, and practice going through that whole scenario. You might just constantly need to mitigate the risk. Think about the potential of secondary injury and the time out implications. So something that's maybe a small injury could become a much more lengthy injury if they continue playing in that game. So make that judgment and be firm with that decision that you have. But congratulations, that is it. We've made it through the assessment parts of this. Hopefully you've pulled lots of things from this that you can apply into your own world. Hopefully makes you feel a little bit more confident about some of the things that you may well be able to identify. Please do get in contact with me if you've enjoyed it, if there's any questions that you have, if there's anything that I can do to support you further. If there's anything you didn't like, let me know. But I really hope that the awareness and the learning that you're gaining on this Grow Physio platform is really helping make you a much more confident and competent clinician. So I'll leave it there and hopefully catch you guys soon in the next session.
Okay, folks, there you go. It is warm. I know that. Does anyone have any questions that you guys want to fire at me? And by all means, feel free to put your sort of microphones on if you want to kind of just talk out, if you don't want to text. I'm very happy to kind of help navigate this because it's not something that I think we naturally go through. So yeah, I'll shut up for a second and then give you guys a chance to ask anything that you want to. Elaine's asked, this was so helpful. That's good. Are there other qualifications we need to have to be pitch side? Yes. So, I mean, at one extreme, you've got thousands and thousands of kids around the world who don't have any physios at all, or sports therapists who are on site. And weirdly, what happens is as you go higher up the ranks and you get into elite sport, there's doctors, paramedics, sometimes dental support that's there as well. There's more than one of you, so you kind of can share that load. So yeah, there's a lot of sport that goes on without any qualifications at all. I'd really strongly recommend going through this material as a minimum on the course, but also go through and make sure you can practically apply it. So there are different sports that will require different pitch side qualifications or acute trauma qualifications. The ones that I recommend are the FISIS, so the pre-hospital immediate care in sport course. So that's run by the RFU. So that's the rugby. So they are the go-to for the whole UK Sports Institute, the old kind of English Institute of Sport. They are the gourmet gold standard. They're approved by the Royal College of Surgeons in Edinburgh. And I just think that the level is outstanding, and why I feel like it's a real privilege to kind of be part of that faculty in the level 2 stuff now. If you're in football, there's a different FA version. So you might well have done the FISIS, but they'll probably make you do the FA one. So if you're self-funding this, make sure that you get the correct qualification. The FISIS is across loads of different sports. The FA one is very specific to football, but you get a nice little trip off and out to St George's Park and kind of go where the England training ground is and have a cracking little day out. And then the other one is the sort of rugby league equivalent. But yeah, I would really recommend do a course. What you ideally want to do is feel confident that no matter what comes at you, you can deal with it. And I think unless you do it practically and get signed off, you won't have that. And that's kind of just the beginning. But yeah, that would be my advice, is go and get an official qualification. There is quite a high-ish fail rate, I think, the first and second times that people do this, because it's so different. So again, I think if you wanted to invest in doing some additional learning beforehand, I'd really recommend that, and it'll make hopefully it a bit more seamless when you get through the course itself. Anyone else got any other questions? Oh, there's one. Oh no, that's me. Anyone else got any other questions that you want to fire at me? If anyone's got any scenarios even that you don't mind sharing, it's always quite interesting to see what you guys have been up to, because although rugby throws everything at you a lot of the time, there's little discrepancies and differences that you might find in your own sports, or little challenges that you've come up against. Or if not, what I can do is wrap it up. But yeah, I'll wait another sort of 30 seconds just to remind everybody that this is all recorded. So I will upload this to YouTube, ping it through to you with your certificates. You can keep that for your sort of portfolios and things from there. Just add your name. Oh, nice. You can go. Is it Toba?
Yeah, sorry. Hi, my name's Toba. I joined a bit late, but I did, have a question. Did you have any like recommendations in terms of like courses? Because there was I do pitch side physio work for my rugby club, for the men's team. And I graduated as a physio just last year. And I know like the minimum requirement was just like a a first aid at work qualification, which I did do. And then just to add on, I did like a concussion course, the one that everyone can access online. So I've kind of been learning as I go. But there is another physio there, which also I've done some shadowing with. But I feel like I've thrown myself into it a bit. But is there any like course you would recommend apart from the like official one on like the England like rugby site? Because I was thinking to do like another course before eventually, I guess, doing that one. Like the level 2 one, I think it was.
Yeah. So it sounds like you've done some great stuff. So I think the kind of classic go-tos are, you can do your kind of World Rugby concussion qualification, can't you, for free online. You can then often do the kind of anti-doping, the UK anti-doping, UCAD qualification as well. So that's quite good if you have kind of any sort of additional responsibilities to try and kind of give people advice, and they talk about what is safe to take and not safe to take and all that kind of stuff. So they're kind of freebies that you can do. I think your sort of first aid at work qualification is great for CPR, isn't it? And kind of choking and things like that. I think for MSK acute trauma injuries, I don't think it even comes close to managing some of them. So I do really recommend the FISIS one, which is that RFU one that you mentioned. It is expensive. So I think it's about 380-ish quid now for the level 2, or it might be about double that for the level 3. It doesn't sound like you need to do the level 3, the stage that you're at. But I think if you can even get some funding from the club to try and do your level 2, I'd really recommend it. I think it's a bit of a when you sit on the sideline and you actually have done that and it's quite fresh in your mind, you feel so much more comfortable than kind of sometimes I feel I certainly felt like I was kind of muddling through before I did that. And if someone does go down, you need to extricate them. Like you don't have any familiarization, do you, with kind of scoops and boarding them and knowing exactly kind of how to roll them and things otherwise. So, yeah, I really recommend doing it. And I think in the long term, it does last for 2 years, doesn't it, before you need to kind of redo it. So it's kind of probably a couple £100 each year. So you could kind of try and, I don't know, get them to pay the £200 or kind of go 50-50 and halfers with them. But yeah, I think if you're in rugby, I don't think there's a better course than that level 2 one to get cracking with, unfortunately. You might just have to dip in your pocket.
Thank you.
That's all right. You're going to hang out. You might get to hang out with me, depending on if we're down at Twickenham or something together.
Oh, lovely.
Be cool.
Yeah. Thank you for that.
That's all right. No worries. Matt's just fired over a question about concussion, ! Talk to me a bit about how you approach this. So this is tricky, isn't it, really? So, I mean, there's key telltale signs of concussion that are immediate removal from play things. And obviously, if they're stumbling, they've ever gone out unconscious, there's kind of elements of doubt, changes in behaviour, all these kind of things that you're gonna find. They're immediate, non-negotiables. They're coming off because they've got some sort of brain injury, be it transient or not. It's the ones that are a little bit less straightforward, aren't they? Where it's a bit more confusing. You kind of go over, they're telling you they're all right. You get to know, some people kind of get them to read things off the hoardings on the advertising boards and things like that, and that's okay. Or they get them to follow your finger as you kind of do it that way. But that's not necessarily enough. And depending on the sport you're in, I mean, I think rugby's ahead of everyone with these HIAs where you've got an opportunity.
Sorry, Steve.
Yes.
Sorry to weigh in. So one of the big things I've been experiencing lately is also referees are starting to step in.
Okay.
So I'll run over to do sort of a basic concussion assessment, and I don't know if rugby's now gone too far the other way. But the minute a referee hears head, they've decided that instantly the player's no longer allowed to play. Did you ever experience that? Is there any way you can? I mean, I'm not trying to argue with referees, but I am trying to make sure I'm doing the best job and also try and keep players on the team, whether it's opposition or mine. But yeah, I found that started happening a lot to me, especially in women's rugby, actually. I found it's happened to me more on a Sunday than it does on a Saturday.
Oh, interesting. So I wonder why that is.
I don't know. Just some of the referees I've been getting because I do Birmingham Moseley ladies on a Sunday and I do Worley on a Saturday. Yeah, when I've been doing the ladies team, the minute the referees are hearing head, I've literally been told to stop my assessment and just take the player off, and they're not allowed to return.
Okay, it's interesting, isn't it? Because there's a common sense approach sometimes, because the amount of head contacts there are in rugby are hundreds, isn't there, in a game? So you can't then take off every single player. But I think there's also the other end where if there's any doubt, you sit them out approach. But yeah, I mean, I guess in reality is I think the referees are there to try and encourage the well-being and welfare of all the players who are there, but they're not medical professionals. So again, it's sort of your role, I would say, to kind of intervene and say, look, we're medically trained, we'll go through a concussion assessment, and then we'll make an informed decision. But you can't just go, well, every single head knock has to come off, because otherwise, you're just going to end up with 2v3 at the end, I would imagine, which ain't much of a game, to be fair. But yeah, I think, what do I recommend? I think what I would do is often, if you go to the referee at the start of the game, before it even starts, and it's not the heat of battle, and you kind of get a little bit schmoozy with them and just go, I'm the physio and I'm looking after the Moseley guys today. This is our approach to concussion. I don't know what your kind of approach is, but I thought it's good to iron it out beforehand. And then it's almost like they don't freak out when that moment arrives. And then you've kind of got a definitive plan. And even if you go in there with some sort of paper that goes through, this is the sort of stages that we're going to go through. On average, it takes 2 or 3 minutes or whatever it is that you think it takes. It shouldn't be too much of an interference for the game, but what we'll do is do that, then make an informed decision. I think when you haven't met referees before and they don't know who you are or what your background is or your experience, I think that's a really good way to kind of just set the scene. And it does mean you're kind of knocking on their door beforehand, and you might be taping everyone up. But often we used to do it when the guys all went out for their warm up. We used to just kind of go, can we just get in your ear very quickly and just do it, or before all the players arrive, just try and get that done. And I think it just smooths the whole process out a bit.
Okay, cool. Yeah, I was thinking actually that might be the best, but yeah, fantastic. Thank you.
That's all right. And it's weird because as you go higher, you can only be qualified at a level 3 FISIS level. So actually the referees are sort of going, well, you guys have got this.
Well, yeah, interestingly, like I hold the level 2 obviously at the moment, but I don't think you even require it until you're national, I think. So yeah, in terms of qualification, I'm holding something. It doesn't mean I know what I'm doing, but I'm holding the right thing.
Yeah.
But yeah,
not too far down the road.
Yeah, but I get that. I think referees are just really aware of it at the moment. Rugby is kind of ahead of the curve on making sure concussions looked at, but I don't know if that's scared a few of the lower level referees to the point where they're like, just take them off.
Yeah, and I think everywhere is kind of going ultra safe, isn't it? I mean, my little boy, he's 10, and basically they did contact rugby for the first time this year. One kid got a concussion, and then they scrapped all of contact rugby for the whole school after that. So it is extreme, and I think people are just kind of a bit overreactive. I think as long as you manage that concussion well, then normally they've had recovery and you've kind of integrated them with that return to play protocol, and then you've kind of done what you need to do and just make sure you obviously document everything you're doing. But yeah, really interesting one. That let us know how you go, because you're only down the road.
Yeah, you started teaching at my university when I left.
Oh, nice. You escaped just in time. There you go. Cool. Right, I'll work through the rest of these questions then. So we have Jordana. We do Lubus, but not sure what the difference is. But I think it's the same as FISIS. I think the difference, I've never done FISIS. I've never done Lubus. I've done FISIS about 15, 16 times now. I think the difference is to do with the accreditation. So I think the standards that are hit on the FISIS course are higher in general. I think the general feel is because you're endorsed by a Royal College of Surgeons, they have more things that you need to hit. So it kind of is the Rolls Royce, the RFU, but I'm sure it will cover the vast majority of things on that Lubus. I think the Lubus course is a little bit cheaper if money's an issue. But yeah, I've never done it, so I'll go from there. Francesco, as the lone therapist on the pitch, how would you manage a player with a suspected spinal injury? That's a very good question. So that is often the case for us, isn't it, in these sort of lower levels, if the money's not great or they haven't got funding for additional sort of staff. What you're going to have to do is, before every single game, is look at who's with you on that occasion. So you're going to have a coach, you're probably going to have the manager, you might have potentially some players or assistants from people who you know are there, it might be parents or whatever. And you might just have to go through a bit of a moulage scenario and explain to them what you want. Now, the main thing that's going to happen is when you go on the pitch, you're probably going to have to apply an anterior hold to that cervical spine, stabilize it, and then basically just teach someone mills. You're going to then go through all of that A, B, C, D, E assessment, address anything that potentially needs an intervention while someone else is applying that manual inline stabilization. The tricky thing is then you are then going to have to swap back in again for mills when you do the log roll, because you're going to have to lead it from that cervical end. So again, it's a bit faffy. You're going to hopefully have done this in training with the staff who you know are going to be with you on that occasion. Go through a scenario, roll one of the other coaches or a player or something in practice, in training. So you're not doing everything on game day, because game day can get a bit stressy. There's obviously loads of moving parts, lots of emotions are flying high. The last thing you want to be doing is kind of going through that. But again, if you're new to a team or you're not really familiar with who's there, you might just have to ask somebody to have that prepped and do a bit of a scenario. The alternative is you just stay there and you basically just wait for an ambulance. So you just stay with inline immobilization on. We've had that in judo where some guy got kind of speared on his head. We weren't happy moving him. There wasn't enough staff who were trained to do it. So we basically just lay there in mills for about 45 minutes waiting for the ambulance to come. The game basically just gets abandoned or paused for the time being, but don't move them if you suspect that there's any sort of spinal injury. So midline tenderness, any inability to kind of rotate to sort of 45 degrees with that Canadian C-spine rules, if they've got any neural symptoms or any just sort of clinical suspicion, then don't move them unless you've got the staff and the scoop and everything to kind of boot and brace them, really. So I hope that helps. Last one, I think. You've all got confident with your questions, which is great. And yours wasn't that scary. So I previously worked as a lead sports therapist at a women's football team, and we didn't have any first aiders, paramedics present for games, so I'd have to deal with serious injuries myself. Yep. I know the feeling. And now going to be starting my first season with a men's football team, and they have paramedics present for games. How do you know who takes the lead for serious injuries, as I am also ITMIF qualified? Very good question. So you might find that the paramedics try to take the lead. However, some paramedics are better than others. If you are confident and qualified to manage that high trauma incident, it might be a kind of stabilizing something, applying a boot, applying the cuff and all that kind of thing. You lead on that because you've got that qualification and it's within your scope of practice. Some paramedics are, well, all paramedics are generally amazing with a lot of other non-sporty related injuries, but they might not have the most optimal management of something like a fracture or a spinal injury. So there's often a little bit of debate around, should I use a collar? Should I not use a collar? If you're qualified and you've been taught to use it correctly, so you're not applying an ill-fitting collar, then use that collar and fit it appropriately. If you aren't qualified and actually you think, oh, this is probably outside of my scope, I'm not rehearsed in this, I haven't gone through this before, I haven't seen this kind of injury before, it might be that actually the paramedics might be the better people to manage that scenario. Now, it's great having them because you've got IV access and all that kind of stuff and defibs galore and all the kit that you might require. The only thing I would just say about paramedics is they often pinch stuff. So if you boarded someone on your spinal board or your scoop and they use that scoop, just make sure you take the scoop off their ambulance just in case someone else gets injured. So yeah, if they're shipping somebody off, then yeah, just make sure you're not left without any kit. There's weird scenarios in the judo, so there's stipulations that you have to have a paramedic on site. So actually, weirdly, although we have the paramedics on site, we have to call an ambulance and get that ambulance to kind of take them away. So we always have the paramedics on scene, just from a health and safety perspective. Brill. Hopefully that answers some of those questions, guys. If I haven't answered them, or you think of anything afterwards, then just drop me an email or get in touch. I can jump on a call with you if that helps. My email's steve@growphysioacademy.com. And yeah, it's been a pleasure. Thank you all so much for tuning in and asking all your questions and things. Enjoy the World Cup. Enjoy a nice cold iced beverage when you finish this, because it's pretty toasty. And I'll follow this up with hopefully an email before kickoff with that recording and everything that hopefully you guys need. But I really hope that's helped prep you. If you want to go through some of that trauma management next month, that's going to be done in this sort of similar format with sort of managing again those sort of high trauma injuries, fractures, dislocations, ruptures, and that unconscious athlete we'll go through. But again, it's all on the site for you if you want to dive onto that Grow Physio Academy, work through all of that material, however best fits your lifestyles, really. You might have a bit of time off in the summer if it's an off season or you're not at uni. So on that note, again, big thanks from me. Hopefully catch you guys soon and take care of yourselves and players.